If you were to take an average adult, shrink them down to about 20 pounds, and hand them a lollipop, would you have a child?
Physiologically speaking, uh, absolutely not. You just have a very small, very confused adult.
Uh-huh. Right.
And, if you try to treat a real child based on that kind of logic, you would be walking straight into a minefield.
And that really is the core theme we are tackling today, isn't it? It's that trap that catches so many people off guard when they first step onto a pediatric unit.
Oh, yeah.
The dangerous assumption that children are just mini adults.
It is the single most important concept in pediatric nursing. I mean, you cannot just take an adult medical procedure, cut the dosage in half, use a smaller needle, and just hope for the best.
That sounds like a recipe for disaster.
It is a complete recipe for disaster.
Okay.
We're talking about a completely different organism, essentially. Their metabolic rates are faster. Their organ systems are, still under construction.
Still loading.
Exactly. Still loading. Their skeletal structure is different. Everything is different.
And that doesn't even touch on the communication aspect. Your patient might be a 6-month-old who, communicates exclusively through screaming.
Right.
Or a 3-year-old who is convinced your stethoscope is a snake.
Exactly. So to navigate this really unique landscape, we're doing a deep dive into Chapter 20 of Lifer's Introduction to Maternity and Pediatric Nursing in Canada.
And the chapter is titled Healthcare Adaptations for the Child and Family.
A perfect title for what we're talking about.
It really is. And our mission today is to walk through this chapter, step by step. We want to translate those dense clinical textbook concepts into a survival guide for nursing students, or really for anyone interested in how pediatric care actually works.
Yeah, a practical guide.
We're going to cover everything from the legalities of admission all the way to the high-stakes math of medication administration.
And we have a lot of ground to cover.
Mm-hmm.
We're going to start right at the beginning, the moment a child is admitted, so safety and consent. Then we'll move into the physical care, how to hold a child, how to assess them without causing a complete meltdown.
Which is an art form in itself.
It truly is.
Yeah.
And then we'll get into managing specialized procedures like oxygen therapy, trachs, and even surgery.
Okay, so let's jump right in with Section 1, Admission and Safety Protocols. The chapter kicks off with informed consent. Now, in the adult world, this is usually pretty straightforward. You explain the risks, the patient signs the form. But in PEDS, who is actually signing?
And this is where it gets tricky immediately. Informed consent implies that the person signing actually understands the purpose of the treatment and, crucially, the risks involved.
Okay.
In pediatrics, the patient, the child, very rarely has the legal capacity or, the cognitive ability to give that kind of consent. So we have to rely on a parent or a legal guardian.
The text mentions the Canadian context specifically here regarding the age of consent.
Right. It does reference back to Chapter 19, but the key takeaway for this chapter is that even while the parent is the legal signer, the nurse has this kind of dual responsibility.
Okay, so what does that look like?
You need the parent's signature, yes, absolutely. But you also owe the child an explanation.
So you don't just talk over the child's head as if they're not there.
Never. That's a huge mistake. The concept is called assent. Even if they can't legally sign the form, you need their agreement, their assent. You need to explain what is happening in age-appropriate terms.
You're building trust from minute one.
You have to. As the nurse, you are the patient advocate. Your job is to verify that the consent form is signed before any procedure happens. If a doctor rushes in to do a lumbar puncture, your job is to be the gatekeeper and say, "Stop, hang on, do we have the signature?"
So you're the last line of defense there.
You really are.
Okay, so once the paperwork is handled, we move to identification. In an adult ward, you might just ask the patient to state their name and date of birth. That doesn't work so well with an infant.
No, it does not. The ID bracelet is the absolute first line of defense, and it must be applied immediately upon admission.
And the text really emphasizes that it has to be snug.
It does. Because children are fidgety, they pick at things, they pull. If that band is loose, I promise you it will be off in 5 minutes.
And the 2 identifier rule that we all know from adult care, that still applies.
Always. Every single time. You check the bracelet, and then you check one other identifier like the addressograph on the chart, or you ask the parent to confirm the name. You never, ever, ever identify a patient by their room number.
Because kids wander.
Kids wander, kids swap beds to play video games, they hide under the blankets. I mean, if you walk into room 302 and just administer a drug to the lump in the bed without checking that ID band, you might be medicating the roommate.
That's a terrifying thought.
It's a huge risk.
The text mentions some pretty interesting technology being integrated into these bands now, specifically for safety and preventing abduction.
Yes, this is becoming much more standard, and for good reason. Many hospitals attach these little security chips or sensors to the ID band. For newborns, it might even be on the umbilical clamp.
And how does that work?
It works just like one of those anti-theft tags you'd see in a retail store. If the child crosses a sensor at the unit's exit, an alarm sounds, it's often a code pink. And in many hospitals, the doors will magnetically lock.
Wow. That is intense, but I guess absolutely necessary.
Has to be.
Let's talk about the physical environment. The text lists a lot of do's and don'ts for safety. It seems like the crib is pretty much the center of the universe here.
The crib is ground zero for safety. The absolute golden rule is this. If you are not directly touching the child, the crib rails must be up and locked.
All the way up.
All the way up and latched. It only takes a split second for a toddler to roll over or pull themselves up and tumble right out.
What about the little escape artists, the climbers? I'm sure you've seen a few.
Oh, many. For them, we use something called a bubble top. It's basically a clear, hard plastic dome that fits securely over the top of the crib. It keeps the child contained so they can't climb out, but they can still see everything that's going on around them.
So it's much safer than trying to, tie them down or something like
Oh,
that.
miles safer. And much less distressing for the child.
The text also gets into the really specific construction of the cribs. It even mentions the slats.
Yes, and this is a standard that comes from, years of things going wrong. The slats should be no more than 6 centimeters apart.
That's very precise.
It has to be. It's to prevent a child's head from getting trapped between the bars. And while we're on construction, the mattress needs to fit securely. No gaps. If there are gaps between the mattress and the side of the crib, a small infant can get wedged in there and suffocate.
That's a silent danger.
Absolutely.
And speaking of suffocation risks, the don't list is pretty specific. No pillows, no heavy blankets tucked in. But there is one rule here that I think surprises a lot of people. Do not prop bottles.
This is a huge one. It's so tempting for a busy nurse or a tired parent to just prop a bottle on a rolled-up towel so the baby can feed themselves. But the text warns very strictly against this.
Okay, it's not just the obvious choking hazard, right? The text mentions ear infections. How on earth does a propped bottle cause an ear infection?
Okay, this is pure anatomy, and it's fascinating.
Well,
In infants, the eustachian tube, that's the tube that connects the middle ear to the back of the throat, is very different from in adults. It's short, it's wide, and it's almost perfectly horizontal.
okay, so it's a straight shot.
It's a straight shot. So if a child is drinking while lying flat on their back, milk can easily pool in the back of their throat and then reflux right up that tube into the middle ear.
Oh, wow.
So now you have this sugary milk sitting in a warm, dark space, and it becomes a perfect breeding ground for bacteria. So propping bottles literally causes otitis media, or middle ear infections.
That is a fascinating connection. So it's not just an arbitrary rule, it's pure physiology.
Exactly. And it also leads to something called nursing bottle caries, which is rapid tooth decay because the baby's new teeth are constantly bathed in formula or juice.
So no propping bottles, period. What about the rest of the room?
It's basically childproofing, but on steroids. You have to keep electrical sockets covered, no latex balloons. If they pop, the pieces are a massive, massive choking hazard.
I think a lot of people don't realize that.
They don't. And here's a big one for the nurses on the floor. Do not let ambulatory patients, so
Yeah.
kids who can walk, use wheelchairs or stretchers as toys. It looks like fun, but it's a crushed finger just waiting to happen.
Good point. Okay, moving on to section 2. Preparation, transport, and holding. We touched on explaining things to the child, but the text really emphasizes honesty.
Honesty is the only currency you have in pediatrics. It's everything. If a procedure is going to hurt, you must tell them.
You can't lie.
You cannot lie and say, oh, this won't hurt a bit, and then you stick them with a needle. If you do that, you have lost that child's trust forever.
And that has long-term consequences.
It does. The next time you come into the room with just a stethoscope, they will scream. Because in their mind, you are a liar.
So how do you phrase it? How do you tell a 4-year-old that something is going to hurt?
You use simple, honest terms. You say, this will feel like a quick pinch, or it might feel a little hot for a second. You validate their fear. You never dismiss it. And, very importantly, you prepare everything before you enter the room.
No fumbling.
No fumbling. If you walk in to do a dressing change and you suddenly realize you forgot the tape and have to leave, that child's anxiety just skyrockets. You need to be a calm, organized, confident presence. Get in, explain, do it, comfort them, and get out.
Let's talk about moving the patient. transporting them from the room to, say, radiology.
It depends entirely on their age and developmental level. Younger children might go in cribs, special wagons, or wheelchairs. Older children can use a stretcher. But the rule, no matter the method, is check the ID band before you leave the unit, and you log where you are going every time.
Now, this next part feels crucial for anyone who's going to be doing procedures. The difference between therapeutic holding and restraints.
It's a very, very important distinction. A restraint is a device, something physical, used to restrict movement for safety. It's often for a longer duration, and it requires strict documentation and a physician's order.
Okay, that's a restraint. What's therapeutic holding?
Therapeutic holding is a human interaction. It's a secure, comfortable, but temporary hold used to keep a child still for a specific procedure, usually for less than 30 minutes. It's a nurse or a parent helping them get through something safely.
The text details a specific technique called the mummy restraint.
Right. Skill 20.1 in the text. It sounds a little spooky, I know, but it's essentially a very secure swaddle. You use a blanket, maybe some safety pins or tape.
And when would you use this?
It's mostly for infants during procedures like a jugular venipuncture or inserting an esogastric tube, things where you need their arms out of the way.
Can you kind of walk us through the mechanics of it?
Sure. You place the infant on the blanket. You take one corner, fold it over their right arm, and tuck it securely under their left side. Then you take the other corner, fold it over their left arm, and tuck it under their right side. You've effectively pinned their arms to their sides so they can't grab at the equipment or the nurse's hands.
And it keeps them safe?
It keeps them safe, and honestly, that tight wrapping often calms them down. It mimics the feeling of being in the womb. It's very comforting for many infants.
And there are other positions mentioned too, like the football hold.
Yeah, that's in figure 20.4. It's exactly what it sounds like. You tuck the infant between your arm and your body, kind of like a football, and you support their head with your hand. It's great because it leaves your other hand completely free, maybe to wash the baby's hair or examine their head, all while keeping the baby secure.
Okay, let's move into the detective work. Section 3, data collection and vital signs. The text introduces a really interesting concept called the touch-free assessment.
This is a critical shift from adult nursing. It's a total change in mindset.
How so?
In adult care, you walk in, you say hello, you put on the blood pressure cuff, and you start touching. If you do that to a sleeping infant or toddler, you will wake them up, they will immediately start crying, and all of your vital signs will be completely useless.
Because crying changes all the numbers.
Drastically.
Yeah.
A crying baby has a high heart rate, a high respiratory rate, and an elevated blood pressure. So the touch-free assessment means you stand at the door or at the side of the crib and you just look.
What are you looking for?
You observe the rise and fall of the chest to get a respiratory rate. You check their skin color. Are they pink? Are they pale? Dusky? You check their position. Are they relaxed and floppy? Or are they tense and rigid? You gather all this data before you lay a single hand on them.
And only after you've done all that.
Then you move to minimal touch. You use your stethoscope to listen, auscultate the heart and lungs while they're still quiet. You save the invasive, annoying stuff, the blood pressure, the temperature, checking reflexes, for the very end.
So it's a hierarchy of annoyance.
It's a perfect way to put it. A hierarchy of annoyance. Least annoying to most annoying.
Okay, let's break down the vitals themselves because the parameters are so different, starting with pulse.
For any child under 5 years old, the gold standard is the apical pulse. You listen directly to the apex of the heart with a stethoscope.
Why not just use the wrist, the radial pulse, like on an adult?
The radial pulse in a small child is often very faint, and their heart rate is very fast. It's incredibly easy to miscount. But there's another really important factor, and it's called sinus arrhythmia.
Okay, what is that?
It's a completely normal variation in children, where the heart rate speeds up when they inhale and slows down when they exhale.
So it's irregular, but a normal irregular.
Exactly. And because of this irregularity, you cannot just count for 15 seconds and multiply by 4. You get an inaccurate number. You have to listen for 1 full minute to get an accurate average rate.
The text has a safety alert here regarding shock, which seems really important.
This is one of the most important clinical pearls in the entire chapter. In adults, we often look for a drop in blood pressure as a sign of shock.
Right, hypotension.
Yes. In children, a dropping blood pressure is a late sign. A very, very late sign. Their bodies are incredibly good at compensating. They will clamp down their peripheral vessels to keep that BP up until they are right on the verge of cardiovascular collapse.
So if you wait for the BP to drop, you've waited too long. What's the early sign?
Tachycardia, a fast heart rate.
Hmm.
If a child is quiet and resting, but their heart rate is just zooming, that is a massive red alert. That's your first sign of distress or shock. Do not wait for the BP to drop.
That's a huge takeaway. Speaking of blood pressure, the text goes into a lot of detail about cuff size.
Cuff size is the #1 cause of error in pediatric BP readings. Hands down. You cannot just grab a cuff that's labeled child and assume it fits. You have to actually measure.
So what's the math on that? What's the rule?
The width of the inflatable bladder inside the cuff should cover about 40% of the arm circumference. And the length of that bladder should wrap around 80 to 100% of the arm.
And if it's wrong, what happens if it's too small?
If the cuff is too small or too narrow, it requires a lot more pressure to compress the artery and stop the blood flow. So you get a false high reading. You might incorrectly diagnose that child with hypertension.
And if it's too big?
The opposite. You get a false low because it compresses the artery too easily. Bad data is worse than no data.
The text also mentions taking BP in the leg. That seems unusual.
Yeah, it's usually done on the popliteal artery, which is right behind the knee. And it's often used as a really important screening tool for certain heart defects.
How does that work?
Physiologically, the systolic pressure in your legs should be about 10 to 40 millimeters of mercury higher than in your arms. That's just due to vascular resistance.
Okay, so the leg pressure is normally higher.
Correct. So if you measure the leg and you find that the pressure is lower than the arm, that is a major red flag for something called coarctation of the aorta, which is a narrowing of the main artery that leaves the heart. It's a simple test that can catch a very serious congenital defect.
Wow. Okay, moving to temperature. The text seems to suggest we're moving away from rectal temps.
Generally, yes. The rectal route is technically the most accurate for core temperature, but it's invasive, it's very upsetting to the child and the parents, and it carries a small but real risk of rectal perforation.
So what's the preferred method?
We prefer the axillary, which is the underarm route for newborns and young children. That's skill 20.3 in the book.
And what about the ear thermometer, the tympanic one?
It's great, it's fast, but there's a little geometry lesson involved. The ear canal actually changes shape as we grow.
I did not know that.
Yeah. For a child under 3 years old, the canal curves downward. So to get a clear shot of the eardrum, you have to pull the pinna, the outside of the ear, down and back.
Down and back for the little ones, and for older kids.
For them, the canal curves up. So for children over 3, you pull the pinna up and back. If you use the wrong technique, the sensor is just looking at the skin of the ear canal, not the eardrum, and you will get a falsely low reading every time.
Down and back for under 3, up and back for over 3. Got it. Now, weight. Why is the text so adamant about using kilograms?
Because weight is not just a vital sign in pediatrics, it is a dosage tool. Almost every single medication is calculated based on weight in kilograms.
And if you use pounds?
If you weigh a child in pounds, but the doctor or pharmacist calculates the dose in kilograms, you could overdose that child by a factor of 2.2.
That is a potentially lethal error.
It absolutely is. So we stick to kilograms.
Mhm.
Always. Infants are weighed naked. A wet diaper can add a surprising amount of weight relative to the baby.
And we also measure length, not just weight.
We do. For infants, we measure them lying down. That's called recumbent length. You just mark the sheet at the top of their head and the bottom of their heel, and then measure the distance.
And head circumference. Why is that so important?
It's vital for tracking brain growth, especially in the first couple years of life. You measure just above the eyebrows and the top of the ears, basically the largest part of the head. We track this on growth charts to make sure the brain is developing normally, and there's no issue like hydrocephalus or microcephaly.
The text also briefly mentions something called the Braden Q scale.
Yes, that's in table 20.1. It's a skin assessment tool that's been modified specifically for children to predict their risk of developing pressure ulcers.
I wouldn't think kids get bed sores.
They can, especially if they're very ill or immobile. The scale looks at things like mobility, activity, sensory perception, moisture, friction, nutrition, and tissue perfusion to assign a risk score.
Okay, section 4, specimen collection. This is where nursing can get a little messy. Let's start with urine collection.
For a potty-trained child, it's pretty straightforward, a clean catch midstream sample. But for an infant in diapers, we use a urine collection bag. That's skill 20.5.
It looks kind of like a little sandwich bag with tape on it.
That's essentially what it is. It has an adhesive rim that you have to stick to the perineum. And the trick is all in the preparation. You have to wash and dry the skin perfectly. If there is any powder or oil or diaper cream on the skin, that bag will slide right off the second the baby kicks.
But there's a big limitation to using the bag.
A huge limitation. It is not sterile.
Yeah.
It is fine for a general urinalysis, checking for a specific gravity or glucose. But if you need to check for an infection, if you need a urine culture, you cannot use a bag specimen
Why not?
because it inevitably picks up bacteria from the skin as the urine flows out. It would be contaminated. For sterile culture in an infant, you have to do a straight catheterization.
What about the dreaded 24-hour urine collection?
And that is the ultimate nursing challenge. You have to collect every single drop of urine for 24 hours straight. If that bag leaks, or if the parents forget and throw away one wet diaper, the entire test is void and you have to start over from hour zero.
That sounds incredibly frustrating.
It can be. It requires a lot of teamwork and parent education.
This section also covers stool and blood specimens.
Right. Stool is usually just scraped from the diaper. For blood draws, the nurse's primary role is often in positioning and holding. We use that hug hold again to keep the child secure and calm.
But the text mentions using the femoral or jugular veins in extreme cases. That's the neck and the groin.
Yes. If you can't get peripheral access in the arms or hands, these large central veins are used. It's very scary for parents to see. And because these are large vessels, the risk of bleeding afterwards is much higher. The nurse has to apply firm pressure for several minutes and then monitor that site very strictly.
And crying makes it worse.
It does. Crying increases the pressure in the head and neck, which can cause the jugular site to ooze or even form a hematoma. So keeping the child calm is actually a critical medical intervention in that moment.
Let's talk about the lumbar puncture, also known as a spinal tap. Figure 20.8 shows the positioning.
The positioning is almost entirely the nurse's responsibility, and it's critical. The child needs to be in a side-lying fetal position, knees pulled up tight to the chest, and their chin tucked down to their chest.
Why so tight and curled up?
Because this C shape curves the spine and opens up the spaces between the vertebrae. It gives the doctor a clear window to insert the needle into the spinal canal without hitting bone. You have to hold the child chemically still in this position. If they twitch or straighten out while the needle is in, it could cause serious damage to the spinal cord.
And what happens after the procedure?
They need to lie flat for several hours. This helps prevent the leakage of cerebrospinal fluid from the puncture site, which can cause a debilitating spinal headache.
All right, so we've assessed the patient and collected our specimens. Now we need to treat them. Section 5, physiological response to medications. This brings us right back to that mini-adult fallacy. Why do drugs act so differently in kids?
It's all about organ maturity.
Yeah.
Everything's just different. Let's start with absorption in the stomach. An infant's stomach doesn't produce significant amounts of acid until they're about 2 years old.
So it's less acidic.
Much less.
Yeah.
So any oral drugs that require an acidic environment to dissolve and be absorbed just won't be very effective.
And what about how fast things move through the gut, the intestines?
Intestinal transit time is very, very fast in children under 5. So if you give a sustained release or extended release medication, it might travel through the entire digestive tract and end up in the diaper before it's had enough time to actually release all of the drug.
So you're not getting the full dose.
Not even close.
The text also has a pretty strong warning about topical medications, creams, and ointments.
This is a major safety issue that's often overlooked. Children have very thin skin, and they have a very large body surface area relative to their weight. They essentially absorb topical drugs like a sponge.
So a little bit of cream goes a very long way.
Way too long sometimes. If you put a potent steroid cream on a baby's diaper rash and then you cover it with a plastic diaper, that diaper acts as an occlusive dressing.
It traps it in.
It traps heat and moisture, which drives the drug right into their system. You can actually cause systemic toxicity affecting the whole body just from a skin cream.
Wow. What about metabolism and excretion? The liver and kidneys?
Both are immature. The liver enzymes that are responsible for breaking down drugs aren't fully functional until about age 2 to 4. And the kidneys, which filter and excrete drugs, don't mature until about 1 year of age.
And the result of that is?
The result is that drugs stay in the body longer. They hang around, they accumulate.
So the risk is toxicity.
A very high risk of toxicity. If you give doses too close together, the blood levels can rise higher and higher, reaching dangerous levels.
The text calls out one specific drug here that's a good example of these issues. Codeine.
Yes, codeine is basically a genetic lottery. It's what we call a prodrug, which means it doesn't actually work as codeine. It's not a pain reliever until the liver converts it into morphine.
Okay.
But the specific enzyme that does that conversion, it's called CYP2D6. It varies wildly in the population.
How so?
Well, some children are ultra-rapid metabolizers. You give them a normal dose of codeine, and their liver instantly converts all of it to morphine. They can overdose and stop breathing from a standard dose.
And the other end of the spectrum.
Other kids lack the enzyme completely. They are poor metabolizers. You can give them codeine all day and they get zero pain relief because their body can't make the conversion to morphine. Because it's so unpredictable, codeine is generally not recommended for children anymore.
So instead we're using things like ibuprofen or acetaminophen.
Yes, but even with those, you have to be careful. Acetaminophen is metabolized primarily by the liver, and ibuprofen is cleared by the kidneys. You have to be mindful not to overload those still developing organs.
This all leads us perfectly into Section 6, medication administration. It starts with the rights of medication.
Right. And in PEDS, the standard 5 rights, right patient, right drug, right dose, right route, right time, are just not enough. We had a critical 6th step, the double check.
What does that look like in practice?
For any high alert medication, we're talking about things like insulin, digoxin, anticoagulants, or opioids. You do your math, you drop the dose, and then you find another nurse.
And you just have them look at your work?
No, and this is the key part.
Yeah.
You don't show them your math. That can lead to confirmation bias, where they just see what they expect to see. Instead, you say, please calculate the dose for this patient. They do it completely independently. Then you compare your answers.
So it's a true blind check.
Yeah, it has to be. It catches errors.
Let's talk about the techniques themselves. Oral meds.
First rule, put the household spoon away. Teaspoons are not accurate measuring devices. You have to use an oral syringe for liquids.
And where do you aim the syringe in their mouth?
You aim for the buccal cavity. That's the little pocket on the side of the cheek.
Huh.
If you squirt it straight to the back of the throat, you're going to trigger their gag reflex and they'll spit it all out. You aim for the side and you push the plunger slowly.
The text has a great tip here. Never mix meds in a full bottle of formula or milk.
Never, ever do that. If you mix an antibiotic in, say, 4 ounces of formula, and the baby only drinks 2 ounces, you have absolutely no idea how much of the drug they actually got.
They get half, a third, less.
You don't know. You can't chart that accurately. You give the meds separately, maybe in a tiny bit of applesauce or yogurt if they're old enough, and then you give them the bottle.
We talked about the eardrops earlier, down and back for under 3, up and back for older. What about nose and eye drops?
For eye drops, you gently pull down the lower lid to form a little conjunctival sac, and you drop it right in there. For nose drops, that football hold we mentioned earlier is great because you can tilt the head back securely and keep it still. That's skill 20.7.
Okay, let's talk about injections. Intramuscular IM sites. This is very different from adults.
Hugely different. In adults, we often use the deltoid muscle in the arm or the dorsogluteal, which is the buttock. In infants and small children, the dorsogluteal is a huge danger zone.
A danger zone? Why?
The sciatic nerve runs right through that area. And the gluteal muscle isn't well developed until a child has been walking for at least a year. If you hit that nerve with a needle, you can cause permanent damage, foot drop, or even paralysis to the leg. We just avoid the dorsogluteal site entirely.
So where is the target? What's the preferred site?
The vastus lateralis. It's the large muscle on the outer aspect of the thigh. It's thick, it's well developed even in newborns, and it's free of major nerves or blood vessels. It is the preferred site for vaccines and IM meds in young children. That's shown in figure 20.10.
And the volume of the injection matters too.
Absolutely. You can't pump 3 milliliters of fluid into a baby's tiny thigh muscle. The maximum volume is usually around 1 ml for small children. If the dose is larger than that, you might have to split it into 2 separate injections in 2 different sites.
What about 5 therapy?
IVs are always a challenge because kids move, they pull, they kick. We have to secure the site very well, often using an arm board to immobilize the joint so they can't bend their elbow or wrist. And we have to check the site hourly.
Hourly seems really intense.
It has to be. If an IV infiltrates, which means the catheter slips out of the vein and the IV fluid starts going into the surrounding tissue, it can cause serious damage very quickly in a small limb. You're looking for coolness, blanching, or puffiness at the site.
The text mentions using scalp veins for infants, which sounds really scary.
It's in figure 20.12. It looks scary to parents, for sure. Little needle taped to their baby's head. But medically, it's actually a fantastic site. There are no joints in the skull, so the catheter doesn't wiggle around and dislodge when they move. It's easy to secure, and it leaves the baby's hands free to suck on for comfort. You just have to spend time reassuring the parents that it is not, in fact, going into the brain.
That's a key conversation. Okay, section 7, medication calculations, the math.
The golden rule, and if you remember nothing else, remember this. There is no average dose in pediatrics. Everything is individualized based on the child's weight.
And it all uses the mg/kg formula. Can you walk us through how a nurse actually does this on the floor?
Absolutely. Let's say you have a child who weighs 22 pounds. First step, always convert to kilograms. You divide pounds by 2.2, so the child is 10 kilograms.
Okay, 10 kilos.
Now, the doctor orders a drug. You open your drug reference book or app. It says the safe dosage range for this drug is 10 to 20 milligrams per kilogram per day.
So you have a range.
You have a safe range. Now, you do the math for your specific patient. 10 kilograms times 10 milligrams is 100 milligrams. 10 kilograms times 20 milligrams is 200 milligrams. So the safe daily range for this specific 10-kilo child is between 100 and 200 milligrams per day.
And then you check the order.
Then you look at the doctor's order. If the doctor ordered 150 milligrams per day, you're good. It's right in the middle of the safe range. If the doctor ordered 500 milligrams, you do not give it. You stop. You call the doctor and clarify the order. The nurse is the final safety net.
The text also mentions BSA, body surface area.
Yes. This uses a tool called a nomogram. It's a chart that plots the child's height and weight to estimate the total surface area of their body. It is considered the most accurate method for dosing because it accounts for metabolic rate even better than weight alone.
And when would you use that?
We typically use BSA for very potent drugs like chemotherapy agents, where the margin for error is basically zero.
Section 8. Nutrition and elimination procedures. Let's talk about the G-tube, or gastrostomy button.
This is a tube that's inserted directly through the abdominal wall into the stomach for feeding. The most critical safety step here is checking residuals.
What's that mean, checking residuals?
Before you pour a new feeding in, you attach a syringe to the tube and you gently pull back or aspirate. You're checking to see how much formula is still left in the stomach from the last feeding.
And if you find a lot?
If you pull back a large amount of fluid, it means the stomach isn't emptying properly. The child might have gastrophoresis. If you add more food on top of that, you're going to overfill the stomach. The child will vomit, and they could aspirate that vomit into their lungs.
So if the residual is high, you stop.
You hold the feeding and you call the provider.
And when you do give the feeding, do you use the plunger on the syringe to push it in?
No, never. We use gravity flow. You hold the syringe barrel up high, and you let the fluid run in naturally by gravity. If you force it with a plunger, you can cause cramping, discomfort, or even damage to the stomach lining.
The text has a very stark warning about enemas. No tap water.
This goes back to basic osmosis. Tap water is hypotonic. It has a lower concentration of particles or solutes than our blood does.
Oh.
So if you put a large amount of tap water into the colon, which has a great blood supply, that water will rush out of the bowel and into the child's bloodstream to try to balance the concentration.
That sounds dangerous.
It's called water intoxication.
Mm.
You can dangerously dilute the blood, specifically the sodium levels. Low sodium or hyponatremia can cause seizures and brain swelling. It can be fatal.
So what do you use instead?
We always use isotonic saline salt water that has the same concentration as the body's fluids. No fluid shift occurs.
Okay, section 9, respiratory procedures. We are dealing with tiny airways here, tracheostomy care.
A trach is an artificial airway in the neck. And because it bypasses the nose and mouth, the air that goes in isn't filtered or humidified. This means mucus can get very thick and can plug the tube, so we have to suction it out regularly.
But there is a very strict time limit on suctioning.
5 seconds.
Yeah.
That is the absolute rule.
That seems incredibly short.
It is. But you have to remember, when you put a suction catheter down that tube, you are sucking out mucus, yes, but you are also sucking out air. You are effectively holding their breath for them.
So you're removing their oxygen.
You're removing their oxygen. If you suction for too long, you cause hypoxia, low oxygen levels. And that can trigger the vagus nerve, which can cause their heart rate to plummet. You can literally stop a child's heart by suctioning for too long.
So insert the catheter, suction for no more than 5 seconds, and get out.
And you bag them, give them extra oxygen with an ambu bag before and after each suction pass to reoxygenate them.
Oxygen therapy itself has its own safety checks.
The big one is that oxygen supports combustion. It makes things burn hotter and faster. The text warns against using any friction toys that could create a spark, or wool and nylon blankets that generate static electricity inside an oxygen tent or hood.
A single spark could be a disaster.
It could be explosive in that oxygen-rich environment.
And because the oxygen from the tank is dry?
It must be humidified. Always. If you blow dry oxygen into a child's tiny nose for hours, you will dry out their mucous membranes, causing cracking and bleeding.
Burn.
We always bubble it through sterile water first to add moisture.
What about choking? The text differentiates the protocol based on the child's age.
Yes. For an infant, so anyone under 1 year of age, we do not use the Heimlich maneuver or abdominal thrusts
Then why not?
because an infant's liver is relatively large for their body and it's not fully protected by the rib cage yet. Strong abdominal thrusts can actually rupture the liver.
So what's the alternative?
Instead, we use a combination of 5 firm back blows, right between the shoulder blades, and 5 chest thrusts, similar to CPR compressions.
But for an older child, the Heimlich is okay.
For an older child, abdominal thrusts are safe and effective.
Hmm.
But for all ages, the one universal rule is no blind sweeps. Meaning, if you look in the mouth and you don't see the object, do not stick your finger in there to fish around for it. You are far more likely to push the object further down and turn a partial blockage into a complete life-threatening blockage. You only remove it if you can clearly see it and grab it.
Okay, finally, section 10. Surgery. We talked about MPO status nothing by mouth earlier.
Right. And in adults, the rule is often NPO after midnight. If you try to apply that rule to an infant who's scheduled for surgery at 10 a.m., they will be severely dehydrated and hypoglycemic with dangerously low blood sugar by the time they get to the operating room. Their metabolic rate is just too high to go that long without fluids.
So the fasting times are shorter for kids.
Much shorter. The rules are very specific. Clear liquids might be stopped only 2 hours before, breast milk maybe 4 hours, and formula 6 hours. The goal is to have the stomach empty to prevent aspiration during anesthesia, but we have to keep the child hydrated and their sugar levels stable.
And what about the psychological preparation? Surgery is terrifying for anyone, let alone a child.
Preparation is everything. For a preschooler, you use play therapy. Let them put an anesthesia mask on a teddy bear. Let them play with the stethoscope. If the equipment is familiar, it's much less scary.
And a practical tip. Always check for loose teeth. You don't want a tooth falling out and getting aspirated during intubation.
Good point. And what about post-op?
Post-op, we're monitoring their vital signs very frequently, every 15 to 30 minutes initially. And pain management is the big challenge. A 2-year-old cannot tell you, my incision hurts, and on a scale of 1 to 10, it's an 8.
So you have to be a detective again.
You're always a detective. You watch their behavior. Are they restless? Are they rigid and guarding? Are they grimacing? Is their heart rate up? You use behavioral pain scales. And you get the parents involved immediately in the recovery room. A parent knows their child's pain cry better than any nurse ever will.
So looking back at all of this, from admission and safety to vitals, meds, and all these specialized procedures, the recurring theme is adaptation. It's the key word. You are constantly adapting the equipment, the math, the communication style, and the safety protocols to fit the unique physiology and developmental stage of the child.
It really hammers home that opening point we made. Children are not just mini adults.
They are a completely distinct patient population with unique physiological and safety needs. If you respect those differences, you can provide incredible safe care. If you ignore them, you put them at serious risk.
And it seems like beyond all the science and the technical skills, there is that element of trust. You know, when you take that extra minute to explain the pinch or let them play with the mask.
You are doing more than just getting through a procedure. You are teaching that child that healthcare is a safe place. You're teaching them that doctors and nurses are helpers, not just people who cause pain. And that is a lesson that can positively impact their health behavior for the rest of their lives.
Well, that brings us to the end of our deep dive into Chapter 20. We really hope this walkthrough helps translate the textbook into something you can use in practice.
It's a lot of detail, but it's all incredibly vital stuff.
A big thank you from the Last Minute Lecture team for listening. Good luck with your studies.
Stay safe out there.
See you next time.